What is your understanding of Dr. Dinerman's examination of Ms. Jemison? And I'll put his note up over there just
well, this is his emergency department note. This is the history of present illness. That's the information that we get when we interview a patient. She told him that it feels like she could not breathe. She feels short of breath. She feels like her throat is closing up on her. It doesn't illuminate on this kind of a screen. The laser doesn't illuminate on this kind of a screen. It's right here. And that's the history. It was also, he obtained the information that she is on an ACE inhibitor that can cause edema. And he had known that because nurse practitioner Anna Train had obtained that information already in the course of her interview and exam of Ms. Jemison. Goes on to indicate on physical examination, he could hear stridor in her pharynx. Remember, the pharynx is the oral part and then back of the tongue, the pharynx, before you get down to the larynx and the trachea. And stridor is noisy respirations. And noisy respirations occur when air is moving past obstruction or swelling. And so this is a clinical finding that the doctor finds when he puts the stethoscope either on the neck and listens or just listens to the patient breathe. He indicated that she was reluctant to talk and says that she feels short of breath. And on his examination, he found significant edema, which is swelling to her posterior pharynx, the back of her throat, and her uvula. Remember that Mallampati diagram we looked at, one being wide open, and where this sounds like this is more of a description of a tree.
And Doctor, you could go ahead and tell the jury what happened after that.
Well,
your understanding.
Yes, at this point, the nurses are aware, the bedside nurse, the nursing supervisor, the respiratory therapist supervisor. When there's an intubation in the emergency department, we mobilize usually multiple staff members to assist with the procedure. The standard medications for a rapid sequence induction or intubation were acquired and drawn up, ready to go. And Ms. Jemison was put on 100% oxygen mask to hyperoxygenate. We call that pre-oxygenate, to saturate the oxygen level in her blood, so that when she receives the medications for intubation and she lays down and she's no longer breathing for herself, there's an oxygen reserve that gives the doctor time to look and do what the doctor needs to do prior to the patient starts desaturating or losing the oxygen reserve.
Okay, so it was pre-oxygenation. What happened after that?
Well, after that, Dr. Dinerman is 17 from the nursing record, and it appears that the healthcare providers rely upon the nursing charting and documentation in terms of their times. One problem we have in emergency medicine is when multiple people are charting critical items and we're all using our different watches. It's not unusual for times to be off a little bit, but they relied upon one clock, which is the nurse's clock, and that's where these times come from.
Doctor, let me ask you this. At the time the decision was made to do the rapid sequence intubation, what is your understanding about whether or not Dr. Dinerman could see the oropharyngeal landmarks?
Well, what he saw when he looked in the mouth and throat is he saw a swollen posterior pharynx and a swollen uvula. It doesn't say whether you could see the back of the pharyngeal wall. It just says that there's significant swelling to the posterior pharynx and the uvula.
And did you read Dr. Dinerman's testimony?
Well, in his testimony he said it was a Mallampati 1, which means it's wide open, you can see everything.
So, Doctor, again, with all of these people mobilized, she comes straight back. Nurse practitioner sees her, the regular nurse, triage nurse, respiratory therapist kind of weigh in. There's a sidebar with Dr. Reed. With all those folks coming in, do you still think the decision to do the rapid sequence induction was gross negligence, and if so, why?
Well, I think it was because they had time. They had time to, with all these phone calls and activations, in a medical center like Gwinnett, which has anesthesia services on a Friday. 9/10/10 was a Friday at 7 a.m., which is when all the ORs, usually cases are getting ready to go. There's anesthesiologists, specialists, surgeons, and doing cases or in the hospital to make a call to anesthesia to call for assistance for consideration of taking a look with her awake to see what you can really see. I think that was critical. I think that paralyzing her was a critical mistake here under these circumstances, knowing that she was a difficult airway because of her size and because of the edema.